So good morning and welcome to Pinnacle Practice Achievement's virtual pop-up event. Today is Saturday, November 11th, 2023. And the title of this meeting is Party Like It's 1999, but don't practice that way. So let's get going. So first, I want to thank our sponsors, which make it possible for our active Pinnacle Practices and Practice Engagement Program members to attend this very informative meeting for free and to keep the cost very low. To non-members, we have Bacco Diagnostics, Podiatry Content Connection, TLD Systems, Modern Practice Solutions, Zimmer Medicine Systems, Elite Orthopedics, ProviderLink, Boz Networks, Footsteps, Phoenix Technologies, and Swift. So preferred vendor pricing and many other valuable benefits are available to active Pinnacle practices. So if you are not a member, go to pinnaclepa.com, click on the PEP membership for more information. It is the most affordable, convenient way to succeed in today's challenging world of private practice. And so that is the Practice Engagement Program. So let's jump right into our first topic of discussion, training for newbies and veteran team members. Most practices have experienced a higher turnover rate than ever in the past few years since the pandemic started. So why is this? In my opinion, COVID-related layoffs and work from home opportunities made and continues to make it challenging to find employees who want to show up to work in person. Higher starting hourly wages and salaries, plus benefits offered by hospital systems and chains like Chick-fil-A make it difficult to compete. A constant revolving door of employees leads to negative effects on practice and employee morale, and we're going to do a whole presentation on that later this morning. But the biggest issue stems from the need to get new hires, quote, up to speed as quickly as possible, and I know that you all have experienced this in the past few years. Overwhelming new hires contributes to high ghosting rates. Again, these are my opinions based on my experiences working with practices of all shapes, sizes, and ages all over the country. So a common question, how do we avoid overwhelming the new hire while ensuring he or she is properly trained and up to speed in a reasonable amount of time? I always say that there should be some kind of an expiration date on the I'm new excuse for not knowing how to do things. Take it slow and focus on what is most important. Otherwise, you will be starting from scratch once again. Worry about the minutia of your EHR later. Okay, this is really a main contributor of employees or new employees becoming overwhelmed. So begin by having the new employee shadow everyone, including the doctor. We'll talk more about that later, to get a feel for the flow of the office. Okay, have them follow patients all the way from check-in to check-out. They must take notes and ask questions. If they are not doing either, they are not engaged or learning. They should spend longer shadowing the position they will be working in, but again, they need to shadow every position in the office, including the doctor or doctors. Provide educational resources and set realistic expectations. Do not expect that a new employee fully understands or can perform a task until they have watched, been educated, and done it repeatedly. There's a lot of people out there that are yes men and yes women who you'll ask them if they understand a concept, if they can do it on their own, and they say yes. And then the proof is in the pudding when they answer the phone for the first time and they have no idea what they're doing. Utilize the staff training videos in the Practice Engagement Program library, online training modules within your EHR. A lot of you are not taking advantage of all that your EHRs have to offer. Provide them training tools, little cheat sheets, guides. I have all of this in my library. And meet frequently. Every individual learns differently, so if one way is not working, try a different approach. Do not expect them to know and understand everything after just a few weeks, because there's always more to learn. Stress the importance of what I call medical customer service. Service with a smile, collecting what is due at time of service, and providing the highest quality care results in improved outcomes, which come from happy patients and increased referrals, overall leading to practice success. Teach them about the common conditions you treat and the services you provide every day. So again, in my library, there's lots to offer your new employees and your veteran employees. There's lessons, quizzes, videos, cheat sheets, guides, protocols, blueprints, you name it. Okay, so just your basic stuff that you're seeing all day, every day. What's a bunion? What's the technical term for bunion? Debridement, basic things like this that we want them to use the correct words. Okay, on the right here, it's a common conditions and terminology staff training tool, just a basic overview, but you really do want to spend the time and go through and teach them what they do not know. Teach them the importance of triaging. And what I mean by this is scheduling patients according to emergent, urgent, and non-urgent on the phone. Okay, you may not think it's so important to train your front desk girl, quote unquote, to understand the conditions that you treat or your protocols, or teach them about the products and services you offer, but they play just as big a part as your back office when it comes to patient compliance, patients being happy, patients paying their bills, patients understanding the treatment plan. So I have this also in my library, separated out into emergent, urgent, and non-urgent visits. So we'll take the emergent visits, okay? And I hope that this is a no-brainer. You've gone over this with your staff, but the other ones, you may not have thought outside the box of more than just the medical necessity, but the practice impact of triaging. So here's what I mean. Obviously, emergent visits are same day, or as I like to say, it's like the Price is Right, like a come on down patient. All diabetic patients with any sign or concern of infection, pain, redness, swelling, drainage, pus or blood, current ulcer that has become larger, more painful or is draining more, injury or trauma. But then here's the caveat. You have to teach them if it's work related, okay? You have to ask if someone calls and said they hurt themselves, they fell, whatever happened, that there's an injury, your first question should be, did it happen at work? You may not take workers' comp, but if you do take workers' comp, a case must be established, a case number assigned for authorization of treatment. You have to evaluate and treat. That's what you need authorization for before you can do anything to a workers' comp patient. So that's a big thing that's missed a lot. Infections like ingrown toenails, especially painful, patients experiencing significant pain referred by their PCP or other medical provider, any type of moderate to severe pain related to conditions such as heel, arch, and ankle. That's your emergent, same day whenever possible. And you might say, well, where am I supposed to fit these patients? We're going to talk about proper scheduling. Urgent visits. I mean urgent schedule between 2 and 4 days. Mild to moderate pain, sudden onset or previous injury that has not improved, lump, bump, discoloration, growth with changes in size and shape. Okay, that should be part of your dermatology protocols. Ingrown toenail that has become red or tender, history of ingrowns, referral from PCP for any reason unless otherwise specified, corns and calluses that are becoming increasingly painful. So here you see we're taking into consideration with that urgent referral from PCP or any other referring provider, okay? Because we want to maintain that relationship that we have with our referring providers, especially now where more and more doctors are being, quote, bought by private equity, by hospital systems, and our referral sources in some areas of the country are seeming to dry up. And then we have non-urgent, which means put them on the schedule as it allows, where there's an actual spot. So we have at risk of routine foot care, nails, calluses with no noted pain, non-covered service, nails only, non-diabetic, cosmetic concerns with no noted pain, second or third opinion consults, patient with a history of missing appointments or no immediate concerns. Okay, so triage not only according to medical necessity, but by practice impact in terms of referrals. And that's the part that may be missing when you have a patient who calls and says, like, yesterday was an observed holiday for Veterans Day today. So it might be someone who maybe they are a town employee or a postal worker and they have the day off and they call your office because they've been dealing with heel pain for the last 6 months. But yesterday they woke up, they stepped down out of bed, they complained as usual. Their spouse said, "You have the day off. Why don't you go and see a podiatrist?" Patient or potential patient calls, and if your front desk person or whoever is scheduling appointments is not trained to see the value of a heel pain patient and getting them in right away, they might not come in today. They might not be offered an appointment today, and you schedule them out 3 weeks and maybe they don't show up. Okay, so medical necessity, practice impact. Review and teach your employees what you learned on the first day of podiatry school, no matter how long they have worked with you. This is mind-blowing to a lot of practices I work with when I do these trainings, and I can see the light bulbs going off over these staff members' heads, no matter how long they've been there. Go through your NL-DOCAT patient evaluation and teach them how, by doing nature, location, duration, onset, characteristics, aggravating or alleviating factors, and treatments, if we get that basic information on every patient, you as the doctor walk in and you're ahead of the game. Okay, so take the time. Again, all of this is in my resource library. This is my best advice for you, especially when it seems some practices have a complete turnover of staff and no one seems to know what they're doing. To me, focus on the patients. Get through the day. Worry about the rest later, which I mean inputting of all the visit information, okay? Your MIPS and macro and all that junk later. Custom evaluation sheets may also help to keep the flow moving when you're shorthanded or in the training process. Again, examples are available in the library. This is an evaluation sheet that I've customized 100 times for my practices, okay? It follows the patient all the way through from check-in to check-out. You can even start to fill it out before the patient gets there. Put in the date, patient name, circle, new or established patient. I have appointment time and arrival time because, as we know, some of your patients show up really early, some late, very few on time. Okay, so that allows the medical assistant to know in what order to take your patients back. There's previous balance on there, copay, deductible, deposit, however they paid, their primary care, the date last seen by the primary care or doctor managing their disease if they're diabetic. If they're diabetic, yes or no. There's vitals, did we check their medications, allergies, and then we have a chief complaint broken into NL-DOCAT. In some of the areas, there's very little writing. It's D for duration, fill in days, weeks, months, and how many. Okay, onset, sudden or gradual, injury, yes or no, whatever it is on the pain scale. Characteristics, I always train the staff that when you ask a patient to describe the pain, if the patient says terrible, awful, those aren't choices in our EHR. So give them some choices: aching, burning, dull, sharp, stabbing, throbbing, tingling, constant, intermittent, and then aggravating and alleviating factors and treatments. And then I put inserts, yes or no. Have they ever tried an over-the-counter or a medical grade or a custom? And then you have little pictures, orders, you have your review of systems, you have if you have performed a biopsy, if the specimen was sent, and then when the patient is to return to the office. Because even though I know you tell a heel pain patient 14 times in that room, we're going to see you back in 2 weeks and check on your progress. When they get to the front desk, if it's not written down, your front desk girl, quote unquote, will say, "Okay, Cindy, when does the doctor want to see you back?" And a blank look comes over my face and I say, "I'm not sure." And then what? The front desk has to get up, go find the doctor or back office assistant, ask when they're coming back. It saves time. All of the things that you would like to dispense, whether it be cash pay or billable, they're also on this sheet. So the doctor circles if they want that patient to have a night splint, they want them to have a CBD muscle rub, they want them to have stretching instructions, whatever it is, they circle it, and it cuts down on the amount of talking between the doctor and staff throughout the day. And then if they get to the front desk or the medical assistant goes in the room to dispense something and the patient refuses, it's that staff member's responsibility to cross it out one line through so we can see what it was, and write in there patient refused, patient declined with the initials, so that gets in the note and we don't accidentally bill for something that was not dispensed. Okay. Once the new hire is comfortable with the basics, so at the front desk, it would be answering the phone, entering in a new patient's information, scheduling an appointment, checking balances. In the back office, rooming a patient, working the treatment chair, comfortably positioning a patient, that's super important. Intaking procedures like your NL-DOCAT, cleaning a room, properly, thoroughly cleaning a room, no rogue toenails anywhere. Then you can incorporate additional training and accountability. Please keep in mind, again, everyone learns differently. So make accommodations if something isn't clicking. Be patient and watch the language you use when correcting, okay? Some people are much more sensitive than others. And I say there shouldn't be so much crying in podiatry, but there's a lot of crying. And I hate to be ageist, but we know that our younger employees tend to be more sensitive. Their feelings just are bigger than maybe the older employees, okay? So watch your language. Meet frequently, check in with the new hire, and encourage them to ask questions, okay? Be approachable. And if red flags are evident early on, it's better to let them go than to waste unnecessary time training. If they show up for the first week and then they start calling in sick on the second, that's a red flag. Also remember that staff members did not attend podiatry school or complete a surgical residency. Let's go back to shadowing. No matter how long a team member has worked in a practice, and no matter which position they hold, shadowing with the doctor or doctors, and very important if you have multiple doctors to have them shadow with each, in the treatment room is imperative. Okay, because I say, why all the commotion? Because common procedures often cause patients to become anxious. We know. Teenage boys with ingrown toenails, right? That's always some kind of a big commotion. Special needs patients, etc. If your front office, the administrative check in, check out, staff members are not aware of what goes on in the treatment room for common procedures and conditions, how can they be expected to schedule appropriately? If they have no idea what's going on in the treatment room, your schedule is going to be a hot mess. So the treatment room should not be a mysterious place. Understanding protocols, products, and services. How do we know when a patient is supposed to return for a follow-up visit? Okay, that evaluation sheet allows us to communicate without finding a staff member and telling them. Who's scheduling follow-up appointments? I like back office, like medical assistants, to schedule follow-ups, especially for your routine stuff. It's easy. It takes 10 seconds. Have them keep little appointment cards in their pocket. Mary likes Tuesdays at 9:30. She comes in every 10 or 11 weeks. Let's have the medical assistant schedule her and then tell her to wave to the front desk girl on the way out and say, I'm all set. I have my next appointment. Happy holidays. How does checkout staff know when and how much to collect for items purchased and dispensed at today's visit? Okay, again, some kind of an eval sheet or communication is essential. And what if they end up not being purchased or they refuse a night splint or a cam walker? Okay, how is this being recorded? It must be recorded in the note, and to make sure that we're not billing or charging a patient for items they have not received. And are all team members well-versed in the products and services offered and dispensed for commonly treated conditions? We'll talk more about this later. And there is an entire scripting section of my resource library. So recently, I've conducted some pretty eye-opening trainings. I was blown away, and I've been doing this for a while. Staff members employed for nearly a decade who knew next to nothing about the cash products and services offered, provided, dispensed in the practices, okay? These are direct quotes from these trainings. I've never heard of that. I just tell the patient to look on the website. I figured that the doctor must have explained it in the room. Our patients don't have money for those things. That's a good endorsement, right? And Swift, isn't that like an ultrasound? No, it's not. It's microwave therapy. So these are the kind of things that if you're not paying attention, this is what your staff members are telling your patients. Okay, so your team should be formally educated and retrained often. Automation works well for some aspects of practice, reminder calls as long as they're working. But robotic staff members do not contribute to success because they need to understand the hows and whys. Okay, do you have regularly scheduled in-services or formal trainings or meetings? If not, you may want to play a game. It's fun, educational, and worth every penny of time invested. This is what I do some of my in-services. It's called the What's My Name game, getting to know and love the medical grade, and physician-only products and services provided at fill in your practice name. Okay, so I've just posed questions. What's the name of the therapy / technology offered in the convenience of our office to treat many common conditions such as plantar fasciitis, Achilles tendonitis, neuroma, wounds? Okay, the answer is shockwave, or like I like to call it pulse wave therapy. It sounds less scary. Okay, so they should be able to tell me about shockwave or pulse wave therapy, okay, and what the benefits are. Okay, can all team members answer patient FAQs like, how does it work? Will it hurt? How many treatments do I need? Does insurance cover it? How much does it cost? How long until I see results? They need intelligent answers to all of these FAQs. Okay. Let's quickly talk communication. Do team members let each other know when they are in the weeds and need a hand, or does chaos ensue? If cross-training has not taken place, asking for help may be counterproductive because they might not know how to step in and help. If doctors are constantly waiting on staff and patients to be prepped and ready, something is not right. The grass isn't always greener. At some point, every one of your staff members and the doctors feel as if their position is more challenging than that of their coworkers. So when this becomes a repeated issue, staff members should be given the opportunity to sit in another seat and try it, and realize there are challenges in every position. So still speaking of communication, how's the communication between the doctor and his or her patients and the staff and patients, because both are equally as important. Did you know patients only hear about 25% of everything doctors say? So how do we make sure treatment plans will be followed? Either repeat everything 4 times or provide them with educational handouts and resources, and thoroughly train staff members to understand conditions and confidently, that's the key, reiterate care plans. So final thoughts. Staff members are real people. To patients, I know that you've all heard me say this before. Remember back to when you were in 2nd grade and you saw your teacher out in public somewhere, at a restaurant, at the grocery store, and your mind was blown because you thought Mrs. Anderson lived at school and she ate chicken patties for every meal and drank milk out of a carton, right? So to a patient, a doctor is like a teacher, not a real person. But staff members are real people because they are the bridge between the patients and doctors. They hold the key towards providing the highest quality customer service and care, resulting in higher compliance rates, improved incomes, and a healthier practice. So never stop working towards improving the systems and communication methods in your practice, and continually educating and training staff to become even more valuable assets. Make efforts every day to show appreciation to your team, and they should do the same for you. Okay, so we're going to move along to our next presentation. Okay, so this is preparing for a successful clinic day, and we're going to run through this one kind of quickly. So efficiency is directly affected by workflow and technology. So we'll discuss technology next, but our ultimate goal is to be efficient. Okay, successful clinic days from a financial point of view means understanding the revenue cycle of your practice. And I do a lot of trainings on this with new staff members, existing staff members, veteran staff members that should know, but no one ever trained them, so they don't. So we have patients, it all starts with patients. Then we have our practice management and EHR. So the documentation and scheduling side, and then the billing side, then it goes to the clearinghouse, which moves to the payer, ideally. And then the payer puts money in the practice wallet, and then the cycle continues. Make every effort to decrease reimbursement delays. So much of this has to do with the efficiencies of your daily practices and billing staff or billing company, checking eligibility and benefits, keeping up with charting, submitting, quote, clean claims, timely filing. Watch these two numbers. If your EHR does not have a report, see if your billing company or biller can help you with this, but it's days to bill, days to pay. One of these things you can control, the other not so much. So days to bill, that to me means how many days does it take the doctor to complete the chart note in order for it to be the claim to be bill ready. I do not agree with doctors who are submitting claims and their notes are not done. Okay, get your notes done 24 to 48 hours after seeing the patient. Hire a scribe if you have to. Keep up with your chart notes. Okay, but days to pay, that fluctuates quite a bit. And that is entirely dependent on the insurance companies and what excuses they're making for not paying your claims. Okay, I have some practices that get paid in under 2 weeks, and I have others that it seems like we're waiting 2 months to get paid. So watch those numbers. Clean claims require patient eligibility and benefits to be verified. Active coverage must be verified at every visit because patients can have insurances that drop them and they don't know. Coding and charges to be submitted according to payer guidelines or LCDs. Place of service needs to be correct. Provider information and patient demographics need to be entered accurately or the claim is rejected. The front office administrative role, front office workflow can have tremendous impact on the overall efficiency and success of the practice. The most frequent source of rejected or denied claims is inaccurate interpretation and input of patient eligibility and benefits. Basically, simple human error, okay? Make sure when you train your staff, anyone that's collecting patient information and entering it into your EHR, you cannot assume the spelling of anyone's name. Do not assume if I tell you my name is Cindy, that is my given name because it is not, okay? Date of birth, repeat it back. Make sure you're not transposing two numbers. Questions for you. Is your staff or EHR system performing eligibility and benefit checks on all patients? I have a little asterisk next to this, Medicare and Medicare Advantage plans, okay? The problem with EHRs that have automatic eligibility and benefit checks is, for example, a lot of my practices use NextGen, and it does, you can set it up to automatically check 24, 48 hours or 3 days or whatever, every time the patient's put on the schedule. But Medicare patients, okay, Medicare age patients, it will show a little green circle, which means active coverage. However, they may have a Medicare Advantage plan, quote, replacement plan, and that's who we need to bill for their office visits. Because they're 65 and they got a red, white, and blue card in the mail. Yes, they have Medicare, but that's only if they're hospitalized. If they maybe watched an infomercial with a retired NFL player on it who told them that the benefits of Medicare Humana, right? And so we need to make sure that these patients are giving us accurate information. Do you know as much as you can about the coverage of benefits or lack thereof prior to a patient sitting in your treatment chair? How is this information recorded? And do you allow this to affect your treatment plans? I would like you not to allow it to affect your treatment plans. You are the foot and ankle experts. You know what it's going to take to get a patient better as quickly as possible. So be aware of what is, quote, and quotes are big quotes, covered or not covered, but be confident in how you present a treatment plan of this is your diagnosis, this is how you're going to get better, whether it's covered or not, that's not your gig, okay? Doctors should not be involved in financial conversations. Patient portals, are your patients using them? Yeah, if they are, they're probably not completing the whole thing. But essentially, portals allow patients to pre-register, fill intake forms as new patients, update insurance information in advance of the visit, request appointments and refills online, receive test results and download their medical histories, pay their account balance. But when it comes to new patients, they're going in there and they're not filling out the longest part, the medical, social, family, allergies, medications. They're not filling out any of those portions. So you just have to do it anyway after they fill out intake forms. Okay. So what if the portal isn't working for you and your patients, which, like I just said, it probably isn't working great. Implement alternative measures to obtain as much information as possible prior to patient arrival. So work with your website provider to include new patient intake forms that are, quote, fillable, okay, in PDF form and able to be submitted securely. This avoids if you mail the packet to your patient and they come in and say, oh, I left it on the kitchen table. That's not helpful to us. Have a staff member in the office or remotely perform pre-visit interviews, like a new patient coordinator. And there's a whole section of my library on this role of new patient coordinator and what they can do for you. Get creative and move new patients through the office in a fraction of the time. So here's an example of fillable intake forms. A lot of my practices that use Podiatry Content Connection for their websites have implemented this. It's a plugin called Grayfish where patients can request appointments, you can communicate with them securely, and they can go in and they can fill out all of their new patient information and send it securely to your practice. And then someone has to enter it into the EHR, but at least you have it. We've even gone as far as to include scanning, the ability for the patient to scan their photo ID, front and back of their insurance card. So imagine that you've never seen a patient before, but when they walk into the office, you can say, oh, hi, Cindy, welcome, because you saw my license picture because I uploaded it ahead of time. Okay. Payer provider portals. They allow you to check eligibility benefits, specific benefits, obtain reimbursement rates, cost estimators sometimes, download EOBs, track claim statuses. Not all provide the same amount of information, which is super frustrating. And then some provider portals, the information they give doesn't exactly jive with what your EHR has given you. So that's also frustrating. And I know it's almost 2024. And why is this still a problem? The answer is nothing that insurance companies do makes sense. Reason for visit, absolutely essential for checking of benefit information, right? Someone is coming in, reason for visit, heel pain, arch pain, foot pain in general. Wouldn't you want to see if a night splint is covered, a cam walker is covered, maybe custom orthotics? And I say covered as in quotes, okay? Do they have the benefit? To prepare for the clinic day, to schedule methodically and create then modifying scheduling rules such as no double booking of similar conditions, right? You don't want two patients coming in at the exact same time that both need x-rays. Maybe you don't want to schedule two patients that both need ingrown toenails because maybe you only have 2 treatment rooms or 3 treatment rooms, and those rooms are at a standstill until the procedure is complete. Also, where new patients should be placed on the schedule. And then huddles. So these are an essential part of preparing for a smoother clinic day. I don't care when the huddle takes place. You can do it before patients in the morning. You can do it the afternoon before. You can do it 2 days ahead for the remainder of the week. It doesn't matter to me as long as it's done. And yes, all team members and doctors should be involved. Okay, because it's not just about that patient's coming in for an ingrown toenail. The mother called and said he's really anxious and she's going to give him a Valium before he gets there, so he might be kind of loopy. No, it's for this patient is aware that they have a $75 balance, and we called them and let them know that they need to clear that up before they're seen today. Because as the doctor, you may be looking out to the waiting room, seeing a patient checking in, and then an exchange at the front desk, and then the patient walks out. And then you go up to the front desk and say, hey, Karen, what happened? Why did that patient leave? Well, it's right in here. We talked about it in the huddle this morning that they were told they owed $75. They needed to pay before they saw you. Okay. Don't sabotage the plan of your front desk person to get you paid at time of service. Okay, there's no IOUs, right? You go to the grocery store, you pay for your groceries. Patients want to see you, they need your expertise, they need to pay at the time of service. Okay, because as they say, preparation is half the battle. So spending that 10 minutes before clinic huddling makes a huge difference in the day. And, you know, some doctors feel like, oh, I'll just let the staff do it. I have an idea of what I want to do for every patient. Your staff doesn't have ESP. They don't know what you want. And if you really get good at it and you really open the lines of communication between front and back office, you use these evaluation sheets or some other method of nonverbal communication. If you really start to put detailed comments on the scheduler, like patients coming in for a recheck of an ingrown toenail procedure, but also wants to discuss or be scanned for orthotics today, put it in the comments, and then we don't forget about it and let the patient leave without scanning for orthotics. Okay, we want to maximize those visits. That's how you do it. Okay, so before we move on, because we're about 5 minutes ahead of schedule, we're going to start with some vendor presentations. Are there any questions? Actually, right here. Can you maybe ask as a poll after what everyone's benefit packages are around the country? So if everyone wants to kind of just think about that for benefits that they provide their employees, we can maybe talk about that towards the end of the meeting. So I will go ahead and I'm going to stop recording here for just a minute and then start again.